ተዘጋጅቶልሻል ዋና ሳሙና ኮሮና 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 ተዘጋጅቶልሻል ዋና ሳሙና ከቫይረስ ለመዳን ለጤና እንዲበጅ ፊታችሁን አትንኩ ታጠበ እጅ ነገ ተባብሶ ከምንጨናነቅ ከተጎዱ እንማር መመሪያው ይተበል ኮሮና 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 ተዘጋጅቶልሻል ዋና ሳሙና በየደረስንበት በያንዳንዱ በር እጅን በመታጠብ እንተባበር በደንብ ከታጠብን እጅን በሳሙና ሀገራችን ምድር ይጠፋል ኮሮና 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 ተዘጋጅቶልሻል ዋና ሳሙና ሳልና ማስነጠስ መኖሩን ካወቁ ቢያንስ ለ2 ሜትር ከስፍራው ይራቅ ለጤና ከሆነ 4 ሜትር መሰብሰባና ሰባትን በደስታ ተራርቆ ይድረስ የጤና ሰላምታ ኮሮና 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 ተዘጋጅቶልሻል ዋና ሳሙና አትረበሽ ወገን ስማኝ በጥሞና መፍትሄ ቀላል ነው ደሞ ለኮሮና ባሉባልታ ወሬ ብዙ አትደናገር ባለሙያ ነው የሚገኝ ቁም ነገር ኮሮና 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 ተዘጋጅቶልሻል ዋና ሳሙና ህፃናት ወጣቶች ማማና አባባ ኮሮና እድሜ አይመርጥም ሁሉም ቤት ሲገባ ወገንን አስተውል ተዋን ዘናጋ ካልተጠነቀቅን ያስከፍላል ዋጋ ኮሮና 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 ተዘጋጅቶልሻል ዋና ሳሙና ኮሮና 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 ተዘጋጅቶልሻል ዋና ሳሙና
Welcome back. Welcome to EpidemiXs TV. Today we are launching a new year's episode. We're gonna start tracking many regions, many countries around the world. We are already on 2021 and we're here today to share our vision, the vision of a wonderful country, a wonderful region, Ethiopia, Africa, with wonderful people that they're gonna explain us in which situation they are, which is the status quo, which is the wave number, and how they are coping with that. We wonder ourselves many times why Africa was doing or is doing very well. Today, we're gonna deep on that chapter into many of these questions, and we're gonna listen our colleagues from St. Paul's Hospital, and also our colleague, Dr. Iñaki Alegría, that he's working in Gambo. So before going on, let's remember what is EpidemiXs TV. EpidemiXs TV, Epidemics is a wonderful project that was launched at the beginning of March 2020, and we've been gathering experiences from all the corners of the world, from Angola, Mozambique, Bolivia, United States, Australia. Many different countries have been representing the colleagues of these countries in what is Epidemics. Today with us, as always, Juan Burgos. Juan, how are you, my friend?
Thank you so very much, Jordi. Very excited to be back on live with you and the colleagues today. In this new year 2021, full of hope and energy to keep on doing great things. And today, as you said, first of all, as Epidemics, we're interested actually in all the different shapes that took the pandemics around the world. And today we are so pleased to have Ethiopia, which is a country belonging to this East African region. We all know that Africa had a very special, particular profile in terms of COVID pandemics. So it's always very interesting to know how these populations, these countries has tackled the pandemics and took them back with their ideas, with their imaginary. So this is one of the main focus of Epidemics to collect this innovative experience around the world and make it public and even like foster their extrapolation, their duplication somewhere else if it's possible. And second of all, I'm very pleased and honored to host today our guest representing two very important structures in Ethiopia, the St. Paul Hospital and the Gambo General Hospital. I think we're going to have two perspectives, very interesting. One from more rural area, one more for more urban area. And this crossover of experiences, I think, is going to be very, very rich today. So thank you so very much, Jordi. I give the word to you again.
Thank you very much, Juan. Yeah, we're launching this new chapter on 2021, and this year will be super special because, as we will announce at the end of the chapter, we're going to launch a super big new chapter called or feature in epidemics called Epidemics Studies, that we will announce that at the end of the episode. But let's keep moving. Let's keep moving into that wonderful country. Let's launch the video of Iñaki Legría and Gambo. Let's go for it.
Estamos en Gambo, a 225 kilómetros al sur de la capital, Addis Abeba.
Cada día es una sorpresa. No sabemos lo que nos espera. Una emergencia, un nacimiento, una cesárea, un niño muy grave.
Nos encontramos ante el Hospital con Alma, el Hospital de la Alegría.
Hace 5 años llegué a Gambo por primera vez y la llegada a Gambo cambió completamente mi vida.
Nadie sabe el número de camas con certeza en la sala de pediatría. Un día hay 45, al día siguiente 57. Gambo siempre está lleno, pero en realidad nunca lo está, ya que aunque estén todas las camas ocupadas, siempre hay sitio para un niño que lo necesita. Gambo puede tener 150 o 200 camas o cuantas sean necesarias. Es el milagro de la multiplicación de las camas de Gambo.
Vine aquí como una experiencia de voluntariado de 4 meses y lo que van a ser 4 meses de estancia se ha convertido en un cambio radical de vida y en acabar viviendo aquí.
Gambo es un hospital de humildes recursos, pero con una gran riqueza de alma. Y eso es lo más importante. Con amor, con esfuerzo y trabajo, es posible pasar de la tristeza e impotencia de pronunciar las palabras «está lleno, no tenemos sitio», a la alegría. Están allí para eso, para entregarse a los demás con alegría, siempre con alegría.
Iñaki, thank you very much for sending us this wonderful video, and I was super impressed about that term, multiplication of beds. So you were able always to multiply beds. Congratulations. Go ahead, please, Iñaki.
Well, thank you very much. It's a pleasure to say hello from here, from Ethiopia. So really, thank you for inviting us, for creating these epidemics, especially for Ethiopia. Well, I'm working in Gambo Hospital, so as can you see in the video, Gambo is a rural area and a rural hospital. Our main challenge is to decrease the highest maternal and neonatal mortality. So due to that, we are developing a maternal and child health project. So we are creating a referral network between the health centers and the hospital, creating like a referral hospital to properly follow up the pregnant woman and to refer the critical ones to Gambo Hospital to do a cesarean section as soon as possible. And also our main challenge during this year is to create the first neonatal intensive care unit in this rural area. And for sure, now happens the pandemic of coronavirus, that we can say that as Gambo is we are a rural area, an isolated area, for sure arrived the corona, but it's not the main challenge at this time. For example, last year, our main challenge was the measles epidemic. We have a critical epidemic of measles. We are 300% of our capacity. We multiplied the beds of Gambo in pediatric wards especially to manage this measles outbreak. And now our main challenge is to create as I tell you, the neonatal intensive care unit, and for sure with the support of one of the most important hospitals in Ethiopia, that is St. Paul Hospital. And now regarding to coronavirus, to the management of coronavirus, I think that the to explain properly the best management of the pandemic of coronavirus in Ethiopia. Gambo is not the best experience because we are focusing managing the maternal and child mortality and also malnutrition. And because of that, we want to invite our colleagues of St. Paul's Hospital to explain all of this properly. So in this way, let me introduce Dr. Berhan Sahai that will explain us properly the overview of St. Paul Hospital.
This opportunity to speak about our experience in response against COVID-19. This is an Ethiopian experience from one of the biggest hospitals in Ethiopia, that is St. Paul Hospital. St. Paul Hospital, Millenium Medical College is one of the biggest tertiary hospital in Ethiopia. And in the last 7 to 8 months, because of the emergence of this global pandemic, our hospital has been among the front line of hospitals in our responding COVID-19 related issues. So I will be presenting few minutes on our experience. How did we respond?
Hello.
Our experience. We have a lots of experiences, but I chose the modality that we have used as something worth sharing. Like, this is a big hospital, as I said, this is a tertiary hospital, but when COVID pandemic has come, some of the hospitals, few hospitals were designated to give care for COVID separately, and then most of those hospitals for the first time, maybe either you COVID care and then you continue your emergency care. But ours, we have discussed with our staffs. We have huge number of staffs. We have enough resources. So we wanted to use the service integration model. So I wanted this as a very good experience to share to the world, because integrating COVID and also continuing non-COVID care is not common during emergency in tertiary care centers. So most of the tertiary care centers, they have their wing apart from their hospital in other centers as a field hospital for emergency pandemic care. They continue their essential care. But what we chose was, we took the responsibility of building yesterday from Dr. Smile. We have built a makeshift hospital or field hospital in other place in the center of the city. And then we continued, or we chose to continue giving service for essential service and also for COVID. So we wanted to integrate these two. So integrating these two needed some other service too. And that we call it isolation or quarantine service. So I wanted to share about these three services, three-pronged services. We continued our essential service, both emergency, elective, and all tertiary care. We also gave COVID-19 care specialty service. Our hospital was used as a specialty referral center for COVID care. And then in between these two, because COVID pandemic has its own emergencies, it has its own new things that we don't know. So patients should be known either they are COVID positive or COVID negative. You have some symptoms, some of the symptoms are known, some of the symptoms are not known, especially after community containment. You don't know who is COVID positive, who is not COVID positive. So while you are giving both essential and COVID care, you have to have a mechanism to separate who is COVID positive and who is COVID negative. And this takes time, at least a minimum of 24 hours. So we also designed the third model, which is called isolation service or quarantine service. It has its own bed, it has its own human capital, it has its own mini ICU where patients will be kept for 24 hours. And then when their test result comes, if it's positive, they will go to our specialty care for COVID. If they are negative, they will join our other essential care. So this is the 3 integrated service we have chosen to continue as a hospital. So while we chose this, we had key pillars for this integration. What did we do? Or what was our design so that we would be successful in this? Is not common, especially I can definitely say in Ethiopia, it's not a common practice to give these 2 services together. So how could we do and what were our pillars? We had 4 pillars, but I will emphasize only on 3 pillars. The first is strong isolation center, the quarantine center, and our own PCR lab. The second is designing and redesigning our patient flow, because COVID and non-COVID care should be separate, because this is contagious disease. This is one of the challenges of COVID is it transmits through respiratory droplets. It transmits through fundamentals of our daily communication. So we have to redesign our patient flow, our staff flow, because those going to COVID, the patients and their staffs should have their separate flow, and then those patients coming for non-COVID care and our staffs giving care for non-COVID should have a separate flow. So that is the second. The third is leadership and systemic potential management. Management during normal condition and management during crisis is different. So during crisis, there are lots of things that you learn, and things are very dynamic. We have seen during our last 7 to 8 months of experience, everything almost we can say has been very dynamic. So in dynamic systems, we need to have dynamic leadership. So the third fundamental point was leadership and systemic potential management and crisis management. The fourth is about our staff rotation and training. So these are the 3 key pillars. I will go into detail of them. I will not take time. The first pillar is, as I told you, isolation service in our own PCR lab. Our isolation service, we didn't start it early, but it has come after we have started both COVID care and our maintained our non-COVID care, and we saw the challenges of triaging patients for both COVID and non-COVID. And then test results, they used to come every 4 to 5 days from our central lab, not our lab, but in the city we have a very big central lab. So tests, they used to come 3-4 days after the first test. So patients stay without knowing their status. Both COVID and non-COVID patients were together staying in our emergency. They are together staying in our ER. They are going to different departments. So what we did was we have 20 bedded small area like an emergency center, which has 20 beds. It has its own 3 ventilators. It's very organized. It has separate staff, single rooms. We don't have common rooms. Every room was dedicated for a single patient. So they will be like, for example, in the morning they come, they will be tested. After 24 hours, their test result comes. They will be disposed from this isolation service area. It can be considered as an extension for our ER, but it has to be the precautions, the hygienes, every standard should be kept high, because we don't know the test results of the patients. As maybe you can see from the graphs, the line charts I'm showing you, in the last 6 to 7 months, you see the patients, the rate of positivity that we have identified in these isolation wards. We have treated more than 1,000 patients in that 20-bedded hospital in the last 7 months, and the positivity rate was increasing. It was 10%, then 15%. It has reached into 60%. Average is 51%. So out of those patients who are tried to be in isolation service, 50% of them are positive. Imagine the infectiousness of the patients. So if they were mixed with non-COVID patients, how much almost our hospital was going to be a factory for COVID expansion. So that was the fundamental thing we did. Average length of stay was 4 to 5 days when we were starting. You see, The second line, if you see the line graph, length of stay. First in is red is in June, and the last one is in August. So in August, almost average length of stay is 1 day. So every patient stays 1 day, 24 hours, but it used to be 4 to 5 days, even 7 days. So this average length of stay has helped us to efficiently use our 20 beds. So we dispatch early our patient. This is one of the was enhanced by presence of our PCR lab. We used to send our patients to the samples to other lab centers, but we established our own PCR, and then we do minimum of 10 tests every day, 100 tests every day, and then we prioritize our emergency patients, our elective surgical patients, and or our other priority patients. And then this has helped our length of stay. The second pillar is coordinated patient flow. As you can see from our designs, we have two big hospitals. One is where it was an old hospital with 290 beds, and the other is a new hospital with 300 beds. In the middle, we have this what we call ER and isolation center with 20 beds each. So the old hospital was preserved for COVID, and the new hospital, which inaugurated 1 year or 2 years back, was preserved for non-COVID activities. So we have to redesign where patients go. If you can see here, we have different doors in our hospital. So we have dedicated a single door for a COVID patient entry and a single door for a COVID patient staff entry. So the staffs will enter through a particular door. They will come. This is the red. This is the red one. The red one, the green one. They don't. They go to the wards, and in the wards, after they finish the activity, they come through the red line, and then they don't. Yeah, and then they come back through the same door they have. They came in. So this is a route for them. But for the non-COVIDs also, we have other routes that we use. Here you can see the staff entry for non-COVID. This is the one with dots. This is for staff entry for non-COVID activity. And then this with a solid line with a green is a patient's history entry for non-COVIDs. And then you can see the COVID ones too. So we redesigned our patient flow, and that has helped us to reduce the contamination of our environment. Both COVID and non-COVID areas will be less contaminated by this patient flow. The other is, I don't want to go about this, organizing. We have trained more than 2,700 of our staffs. And then we didn't dedicate a single rotation basis. So for 2 months, people will be working in COVID activity. They will be tested when they come out. And when they are negative, they will join the non-COVID activity. Those who are in non-COVID, they will go campus distributing one. This is once in a while phenomena. You don't, these types of pandemics, they come once in 100 years. So we have to experience, all of our professionals has to experience this pandemic. So we wanted everybody to experience, to go through this experience. And then we trained all the staffs, and we did a rotation schedule so that we could go. And then the other important thing we did was we have also shared services, like for example, diagnostic services and other pillars like laundry, CSD, oxygen plants. These are, we cannot dedicate them because you can't establish a big laundry within a month. So we wanted to share, and while we're sharing, we developed a protocol so that our staffs will use in a wise manner. So this is the third pillar. The fourth pillar is about leadership. So this is the most important part I want to discuss. I have here 4 points that I brought. Our leadership, especially our hospital management. This was the first time we had such disaster. So during such disasters, we have to be very dynamic and study our potential to respond. Can we really respond for such? That was what we first did. Yes, our members, our hospital, our faculty, our academic, our administrative staff, our clinicians, all we gathered together, the representatives, and then we saw our resources, our capital, our buildings, and then we said, yes, we can respond. How can we respond? We can do like a makeshift hospital, like we did with Millenium COVID care. That was 1,000 bedded hospital. So part of our hospital teams went there. It was a big hall. It was a dancing meeting hall. They turned it into a hospital. That was our staff. And then the remaining members of the hospital also made ready our established hospital for a pandemic response. So the first thing was potential to respond. The second thing that we did was we didn't want to be, so we wanted, like, for example, these things might come 10 years after. And then immediately next year, we can have something like this. So we wanted to learn from our process. To go through our learning, we wanted to monitor and measure what we are doing. This is the graph I'm showing you, the bar graph showing the preparedness. It was 20%. Our hospital was prepared to respond only for 20% of our WHO checklist. So we regularly were checking and checking. Now it is 70%. This was 54% was just in August. After September, it has become 72%. We were continuously improving. So we were measuring how prepared are we, and then we were assessing also how were our medical care of quality, how are we giving our ICU cares. We audit our mortality. These are the things. So we used to monitor our performance. The other is we also were ready to anticipate what is coming. The second graph I'm showing you, this will be a paper we will be published very soon. It says, like, one of the first things that we had faced was in our emergency, patients come, they don't have clear symptoms for COVID, but they have hypoxia. One of the patients we had was nobody checked because she was walking. Nobody checked and nobody suspected that she's in distress, and nobody suspected that she has hypoxia. So what? She was admitted to emergency ward. She was treated. She stayed 4 days, and then later, when she started to deteriorate, we tested, and when we tested, she became COVID positive. So we took this as an opportunity, and we did what we call FMAEA, Failure Mode and Effect Analysis tool. It's a quality improvement tool. So you don't necessarily need to have a problem. You can anticipate the problem. It could happen, but you will respond by saying, how could it happen? Where could it fail? What is the likelihood of its failure? What is the percentage of its occurrence? And then how severe it is if it occurs? And then what possible change ideas can you bring? These are the models that we use. So what we did was in our emergency, in our operation theater, in every field, we use this tool. And then before such things happen, we designed improvement ideas. And that is what has brought what we call also isolation service establishment. So we learn from our mistakes, we learn new things, and then we anticipate problems coming. And then before they happen, we get prepared ourselves. The third is learning. So we learn from all our mistakes, we learn from our good things. We have lots of protocols, we have lots of guidelines we have developed through our monitoring and through our anticipation and through our capacity for response. So these are the response. So these are the 4 basic things that we have faced with resources. These are the face mask, the N95. These are the ones that you use for infection prevention. I tell you, this is the most difficult job we have seen in the last 7 months. What we did earlier was using all the resource we have. We used to distribute for a month or so, but that was very impossible because we will run out. We immediately ran out of our resources. But what we did with our learning experience was we developed a system that could trace and that could anticipate for the coming 6 months. It audits our monthly activity, and then it fixes what went wrong, and then it predicts for the coming 6 months. And earlier, we procure such equipment. So that was one important thing we have learned. So this is all about our system integration issue. These are the 4 major important activities, pillars of activities that enabled us to give both COVID and non-COVID care. In the last 2 slides, I will tell you some of the data about our COVID care. As I told you, our COVID center was meant to be built for a specialty center. It was a referral center. So what we had an ICU care, we had dialysis care, we had operative care, surgery, general surgery, and all other specialty. Also, we used to give mental health, and then gynae obstetrics and also pediatrics was our, we used to treat these patients too, and also our special population, NICU, neonatal ICU care units, transplant patients, because our hospital is one of the hospitals which gives kidney transplant. So these patients also could be tested positive for COVID, and they don't have other place to be treated. So we also made ready for our hospital for such special population. So totally, we have dialyzed more than 141 patients. We gave around 992 dialysis sessions. So we are the only hospital that was dedicated for COVID dialysis. So we have AKI and CKD patients. We have dialyzed 141 patients. There were another hospital which used to give surgery for COVID patients, but we were among the biggest one was out. So we operated on 52 patients, both general surgery, orthopedics, neurosurgery, all emergencies. We did mental health, not typical for us, but we handled lots of mental health patients with our psychiatric staffs. We have attended around 84 deliveries, out of which 15 were cesarean section deliveries. So, and also in pediatrics, we had 103 pediatrics population, out of which 6 pediatric patients died. We used to give CT scan, echo our patients, and our laboratory. We used to have cytology, biopsy for our COVID care and special populations. Totally, we have treated greater than 1,700 patients, and out of which we have treated around 261 ICU patients, and 87 of them were discharged. One thing interesting in our patients, we have intubated 161 patients in our ICU, and amazingly, 17 patients were extubated. This is 10%. This is a very big figure. The global figure is not more than 3% extubation, but ours is around 10%. So this is a very, we are studying what is the good thing that we did, how different were our patients, what were the indications. We are studying these things, but generally 10% of our intubated patients were extubated. This is, we will go through the details of this, but this is one of our findings. The other is our specialty care, our social service, as it's just one single data. Our delivery, we used to attend, see this, 1,000 is the bar. So every month in our hospital, 900 patients to 1,000 patients delivered. The one with orange color is last year, 2019. The one with green is 2020. It's comparable. So not reduced. March, April, May, till August, no patients not reduced. So we continued our maternal care, our pediatrics care. If you see our elective, gradually it has increased. And now per week we do more than 90 patients per week in general surgery. This does not include emergency surgery. So diagnostic outpatient continued. It was interrupted for 1 month, but later gradually it was increasing, and now we are in a similar used to treat last year. So these are some of the activities that we had in the last 7 months. I thank you for listening.
Thank you, Dr. Berhan El-Sahai, for this overview of St. Paul Hospital. And now let us give the word to Dr. Ismail, that is going to explain us properly how St. Paul Hospital is managing the coronavirus.
you, Epidemics TV, for having us on your TV to share our experience. So I am head of Millenium COVID Care Center. This is the largest COVID treatment center in the country. So Millenium COVID Care Center is established under St. Paul's Hospital, Millennium Medical College. Before I start, I would like to give you a perspective. Why did we need to change a convention center into a hospital? This is very important because Ethiopia was not a country that's privileged in resources, as you may know. The number of total ICU beds in the country when we started, when the epidemic started, was only 300. 300. If you calculate per 100,000 population, this is very, very far below even for African standard. And if you take the number of ventilators we had, it was far less than one. And if you see the data for Africa is about 3 ventilators per 100,000 population. So there was a very, very, very severe need for expansion of the hospitals. So I'll be sharing with the slides what did we do and what did we learn from the experience. Next slide, please. So this was Millennium Convention Center. It's about 6-hectare compound, the whole being about 2 hectares, 20,000 meters squared. Next slide, please. So this is after preparation before the patients enter the hall. So these are the wards. So next, so these are after patients have been admitted to one of the wards. So I will explain later on. Next, please. So this is a different perspective. Next, please. So this is one of the ICUs. I just want you to have a real image of what's going on in the hospital. That's why I gave you the image first. Next image first. Okay, this is also an ICU. Please go on. This is a lady on CPAP. We use for CPAP mid-range ventilators, but we use invasive mode for non-invasive ventilation. So go on and I'll explain later. Now, what did we do? So one of the challenges was the structural transformation of a convention center in Ethiopia and Africa into a hospital. The second challenge was is recruitment and training of staff, because we had only 300 ICUs, so the number of people who are trained in critical care and in management of this kind of illnesses, it was very limited. Please go on. The third one was preparing of the software, the protocols, the SOPs, and the TORs for management of the new hospital. Please go on. So the last one, the most important one, was initiation or delivery of care. So I will take the next 5 minutes reflecting on these pointers. Next slide, please. So when we see the timeline, please go on and expose the slides as I talk. Slides, we were given the order to change this into a hospital 1st of April, and we started accepting the patients 1st of June. In 2 months, we had to make a 1,000 bed hospital ready. So this involves setting oxygen lines with manifold system and copper wiring distributed all over the hospital. This involves installing a ventilation system per CDC WHO recommendations for acute respiratory illness isolation. This involves setting sanitary lines, because this is a convention hall and it never had sanitary lines. It never had washing facilities, because the washing facilities are outside the hall. So somebody has to travel a long distance, which is very difficult for somebody who is sick and difficult for infection prevention perspective. So by mid-July, we opened the ICU. Initially, we opened the ward. By mid-July, we opened both ICUs and started functioning. So this is generally about the timeline. Please go on with the slide. Please go on, please. The next slide, please. Next slide. So now I will give you some detail about the hospital. So please keep on exposing the slides as I talk, so that I will not say expose the slides time and again. Please keep on just projecting. So the hospital has 1,000 beds. From these, 40 were designed to be ICU and HDU. 86 had capacity for high flow oxygen, more than 10 liters oxygen provision via a central distribution system. The rest have low oxygen capacity with concentrators which can deliver up to 10 liters of oxygen. And we have a moderate mild risk capacity, and we had a step down unit in flow management area because we were afraid that we might be overcrowded with patients, because we saw what happened in Italy. We saw what happened in big countries with a lot of resource. So we were afraid, and we were underdogs, as you may think, because of our resources, because of once this thing goes to, just calm it down, please. Once we go to, when the epidemic happens, we were scared that we might be over flooded. So we had a flow management area dedicated for this purpose. So I'll come to this picture again. So the next thing we did was we have to establish the protocols and the softwares. In these were guys working in the quality department at St. Paul's. So the idea of quality improvement is a new idea. Even in the best countries with best quality improvement in healthcare is not utilized to its maximum. So these guys are quality improvement trained. They are trained with the tools for IPC, flow design. So these are young physicians, young nurses. Were in St. Paul's. We took most of the team in St. Paul's and brought it to the center to help us design the flow, to help us design the IPC protocols, to help us adopt data management, the design of the hospital. So myself, I was director of quality and clinical governance at St. Paul. So we brought the quality team, and to add, this has been very, very useful to us. Very useful to us, especially in IPC design of the hospital, in designing innovative ways for recycling of PPE and other scarce resources which are not available abundantly in our setup. Next slide, please. So the other is staff recruitment and training. These were young nurses and physicians who were graduated from universities and waiting to be deployed in areas, so they had to be trained. And we had total of 569 staff. 323 of this was clinical staff. And the other were support staff. Please go on. So these are nurses working in the ICU. These are two nurses that are in the ICU. So go on, please go on. So when you come to protocols, one of the problems, the gaps we had was communication in exchange of patients, transfer of patients to better facilities. This was a challenge. So this was my liaison officer communicating with the ambulance system in town. So establishing a structured questionnaire where information is not missed and patient does not happen to the patient in exchange was something very important. The quality officers helped us do. Like Firal is here, maybe he will reflect more on this. He's a young doctor who was working in Gambo and working in our data management unit. Maybe he will reflect later. Please, next slide. So these were the areas of protocol design. So I will not go into detail into each of them, especially adaptation of case management to our setup, because our setup is different as far as resources are concerned. Our culture of care is concerned. Many things are concerned. Availability of drugs is concerned. So adoption of this is very important. The other thing is research protocol, because if you don't embed learning in a health system, in any health system, it will be difficult to improve, understand your problems, and deliver better care every day. Next slide, please. So the next one is initiation of operation. So far, we have seen close to 4,000 patients. 4,000 patients. So from these, 2,955 have been discharged already. The mortality rate, the crude mortality rate, about 6%. If you take severe patients by WHO criteria, at least having desaturation less than 90, requiring oxygen, the mortality goes to 18%, 18%. So far, we had 238 deaths. So if you consider the magnitude of this, 1 in 10 days in the country is in this center. 1 in 10 days in the country is in this center. So this is a very important data. So please go on. So this is the ICU, care provided in the ICU. If you see the age distribution, most of the patients are very young patients. Very young patients. The median age for days is 58 years old, which is very young. But if you see it for the population age, 70% of the Ethiopian population is less than 30 years of age, less than 30 years of age. So this reflects mainly the population age distribution, but still days is at a younger age relatively compared to data in the West or in China or other countries. So this is the admission age distribution. Please go on. So if you see the triage score, initially we were being used as a public health response until we opened the ICU. So anybody who was suspected to have COVID is not late in the house. He has to be quarantined in a center. I think this has helped significantly to flatten the curve for the country at large. So people were admitted significantly. If you see the curve, the mild cases were initially, most of our patients were mild cases. It was a public health measure of isolating an infectious person. So, but now if you see subsequently, now if this one, the yellow slide is for the orange slide for severe cases. It has been increasing significantly, and now we don't admit mild cases. We admit either severe case or moderate case with a complicated other comorbid illness. That's what we admit. So the trend tells you the course of the epidemic in the country and the course of our center initially being used public health isolation center, subsequently as a management hospital for civil patients and critical care. Next slide, please. So this is the same slide. Go on, next slide. Okay, this is a comorbidity, the same issue. Initially, we were admitting young infectious patients who do not have any comorbidity, But now if you see, more than half of my patients have comorbidity. Hypertension, diabetes, hypertension being the leading cause. More than 60% of my patients having hypertension. Next, please. Next. So this is the distribution of the comorbidities, I think. So what are the lessons? This is very important. What are the lessons? Next slide. So what is, we employed, there was a remarkable political commitment in the country to fight COVID. This was unusual for us because in Ethiopia, priority was not that a priority for a long time. And if you see, for example, Abuja Declaration, we are signatories to Abuja Declaration to increase percent GDP contribution to health, but we are not one of the countries who are fulfilled. We are still about 3% of the GDP is dedicated to health. I understand this because of the many issues the country is having. But when COVID came, we had the full attention of the government. And we employed that to upscale ICU design, to upscale hospital design, because ventilation system for acute respiratory illness isolation standard never existed in the country, even in the best ICUs. Even in my ICU at St. Paul, at the main hospital, it didn't exist. But this time we convinced them that it's cheap, and it is cost effective, not only cheap, because value to cost is cost effective. Please go on one slide up. One slide up, please. Back, please. Okay, stay here for some time. Stay here for some time. So the other is the central oxygen distribution system. We used to roll cylinders in the corridors in the past. This time we had a central oxygen distribution system with copper wiring. For you guys working in the better setup, this is, you may take this for granted. For us, this is a big leap, because only a couple of hospitals like St. Paul had a central oxygen distribution system. So this is a leap. It's wash strategies, the washing, the toilets, mobile toilets, sanitary lines, which are innovative, built by our engineers, the hospital engineers. So we used the government, the opportunity of the political commitment to transform what our politicians think about what a hospital is all about. Next slide, please. Next slide. The other is embedding learning and research, because if you are a beginner like we are, you're not going to learn from Europe and America and expect to solve your problems. So we designed a research protocol, and we started collecting data. We established a cohort and started collecting data. We have already compiled about 8 manuscripts, which have been sent for preprint, and WHO has taken all 8 as a resource material and published them. And we are hopefully, once they are published, we will post them on EpidemiXs study. It will be a big opportunity for us. So these are the topics. I will not go into detail into them. I'll go into some. So these are, some of them are very interesting. Have interesting findings. I can send you the links. Next slide, please. So this is the list goes on. So let's go next, please. So the other is economic use of PPE and recycling, because we had difficulty. We were, there were the threats of PPE running out. So we had to instill a mechanism to recycle, a mechanism to produce PPE at our IPC center. So our young physicians and nurses were very instrumental in this. So we bought sewing machines here. We bought sterilizing UV sterilizers, autoclaves. So we buy raw materials for this, and we prepare most of the PPE here and sterilize and reuse our PPEs here. That has been very, 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 very useful, because when we had out of N95, when there's a scarcity of N95 in the country, we had never a problem with our care, and we had never a problem or concern for our staff to be exposed for COVID. Please go on. So before I finish, I'm left with 2 slides. Challenges. This is a very important challenge. 2 important challenges we had. One is weak supply chain. So the country generally had a weak supply chain system. So even those drugs which we can afford to buy, the process is very tardive. They come very late and in poor quality. This is an issue. So we have to struggle with drugs for critical care, for sedation, vasopressors, antibiotics needed for care of critical patients. We had a problem. The other is lack of previous experience. We never had an experience of running such an emergency hospital previously, and that was remarkable. And the fact that we embedded a learning system and quality improvement helped, but it still was a big challenge. And the third one was culture. So our critical care culture, our safety culture, our culture of person-centered care provision was not of high standard. Maybe if you go to Gambo, a rural hospital, or a random hospital in Ethiopia, our culture is not of the standard we wanted to be. So that was a significant challenge. So this was in brief what I can tell you about our experience. So if there are questions, I would be very, very, very happy to respond. Thank you very much.
Well, thank you very much, Dr. Ismael. So for all of us, it's a big honor to be with you. We are learning a lot with your experience, and for sure we have a lot of challenges that working together we are going to improve day by day. Now I want to give the word to Dr. Lydia. So please, Dr. Lydia.
Thank you very much. It's an honor for me to be in this program. I think Dr. Ismail before me explained very well on the key areas where they have to pass to create this very critical center for our country. So in St. Paul, first I'd like to start when we first learned of the epidemic of coronavirus. So to be honest, all of us were really scared because, as you all know, we have a very not that much strong health system, and our hospital being one of the biggest referral hospitals in Ethiopia, we were already overcrowded with other patients like maternal cases or other infectious and non-infectious cases, and our emergency units were also extremely busy, and they were extremely overflowing with patients. So our first reaction to learning about COVID-19 was we really hoped it wouldn't come to our country because we already have an overstretched health system, and it was a very big concern for us that if we have additional patients of COVID, then that will be a very, very big challenge for our health system. But once the COVID epidemic started in our country, then we started having patients, and the first thing we did was, I'm sure Dr. Brana will explain in detail of what we passed through, but we have learned that not only we were able to start a 250-bed COVID treatment center, which is a separate center from Millenium COVID treatment center, which was located in St. Paul Hospital compound. And we were able to do that because, one, we shifted, we had a new MSH building, and we shifted our other surgical and medical services into that new building, and we converted our previous building into COVID treatment center. So I think the first one was, it was new for us, the whole managing what the patient burden that we already have, and additional having patients referred to us, especially those who need critical care, and also which demanded a very high amount of oxygen, unlike the patients that we had previously. So it was challenging. I think I can say that it was really challenging, but we managed to prevail through it. And one of the reasons, as I mentioned earlier, one of the challenges actually was to actually establish patient flow and how to triage patients and also how we were going to manage patients. Are we going to mix them or not, or how are we going to find out? And this and that was very difficult for us at the beginning, but through time, because we had very talented and really I have to say thank you for our hardworking physicians and nurses and quality expertise and other health professionals. They come together, created a team. And the most important thing I can say about this issue is that the best thing that we did was we learned as we go. So we tried different methods, and then we learned as we go. We tried to adapt to the new challenges faced, and everybody was working 24 hours, 7 days a week. And I think that should really attributed on the management of COVID center and creating a big center in our hospital. So the most important thing was the key team, where they had many sub-teams below them. And what they did was they evaluated, they created protocols on how to patients, how to categorize patients, and created an isolation area where patients can stay until they were diagnosed or decided whether they are COVID infected or not. So I think this was very, very critical. The other key area is after we started PCR testing for COVID, helped us a lot in our management of cases, because initially we had a very difficult time. We will admit patients in our isolation area, but to get the COVID result, it took more than a day or 2 or 3 days, and that really caused a very big problem to stratify patients and to manage them accordingly. But once we started our PCR testing in our hospital, I think that problem was relatively alleviated, and we were able to stratify patients and go on accordingly. The other thing we did was our health professionals were double burdened because they have to work both in COVID centers and in a non-COVID hospital. And our specialists and subspecialists were also on duty on both centers, and they have to do that in rotation. And that was, I think, a little bit difficult. The other thing, I think Dr. Smile already mentioned it, in an already overstretched overstretched hospital where we had challenges of providing, having adequate mechanical ventilators, adequate critical care medication, and well-trained personnel in the critical care. I think that was challenging, but also it has created an opportunity because now we have a lot of trained nurses, trained physicians who can manage critical care patients in our hospital and also rotate and work in other ICUs as well. So it was not easy, but through it all, we have learned a very big lesson from this and how to approach and manage epidemics even in a setup where the health system is already congested and stretched. So I think the most critical thing we learned as we go, and everybody was willing to work more than the delegated working hours. And everybody, I think, was acting like a soldier. When they were told to go here, they go here, and then when they were told to go there, they went there. So more it was a learning opportunity for us. And currently, I think the big challenge what we are facing is the shortage of mechanical ventilators, and still we need to keep on training where we also have COVID positive and COVID negative patients. So overall, I think it was a very big learning experience for us, and I believe we managed it very well, in my opinion. And a way forward for us, I think, is the integration of services, because as the number of cases are increasing, we cannot just rely on very few centers where we can send patients whenever they are tested COVID positive. So I think the way forward will be integrating COVID services in all hospitals, in all health centers, able to manage this just like other patients. I think that's very, very. And the point would be to invest really hard on our critical care services. So one thing I'm hoping to see after COVID epidemics has actively alleviated is it will greatly impact and force our country to strengthen the critical services of nation. So overall, well, this is what I can think of in the top of my mind, but if there is any other questions or areas you'd like me to clarify, I will be more than happy to do so. So thank you very much.
Well, so really, thank you very much, Dr. Lydia, for this full explanation. Really, I think that St. Paul Hospital is doing a big effort, and if Ethiopia, and especially St. Paul Hospital, is managing properly the coronavirus pandemic, is due to the hard work of all the staff, hard work of all health professionals working for doing the best quality and working with the excellence and the best protocols in Ethiopia. So I think maybe this is the most important I want to say, and also to be adapted to the situation. I mean, not only managing all the patients with coronavirus, also continue the essential health services. So I think it's very important to remark that Ethiopia is working with all the essential health services, and also as Dr. Lydia, as medical director, but also as pediatrician like me, it's very important to continue doing all the deliveries of pregnant women, and also managing properly the neonatal intensive care unit. I mean, due to the coronavirus, we cannot increase the mortality of pregnant mothers. Also, we cannot increase the neonatal mortality. So it's just to fight against coronavirus without decreasing the other essential health services. And I think this is a big challenge, but the St. Paul Hospital is doing really properly due to the hard work and working with quality and excellence. So really, I appreciate a lot. I'm learning a lot, and for me, as a Gambo hospital, it's a big pleasure to have the full support of an excellent hospital like St. Paul Hospital. And now, finally, we want to give the word to Dr. Firaol, that is working in St. Paul and also was a GP working in Gambo Hospital. So he's the person that knows properly the both place systems. So really, it's a pleasure. So Dr. Firaol, please.
Okay, thank you for you give me this opportunities. I'm Dr. Firaol Mohammed. I'm a general practitioner who currently working in St. Paul Hospital under Millenium COVID-19 treatment center. Before that, I was working with Dr. Inaki Alegria in Gambo General Rural Hospital, and it is a big opportunity and it's a big honor to be on this stage with one of the best team leaders like Dr. Ismail, Dr. Lydia, and the others. So having said that, I would like to share my experience during this pandemic from the beginning, because I was one of the few few members of the or colleagues who work with Dr. Ismail during the beginning of the this center. It was, as you know, that it is an entertainment hall, so converting this is not a very simple job, which is need both the structural, which is the engineering part, which is very time taking and it's very tiresome. Also, which is also include the functional part, which is mainly dealing with the how the hospital should be functioning, because that is the most important thing later on. And we were given that assignment by our by Dr. Ismail. So after given a direction, we were focusing on 3 areas to change, the center's functionality. We were given the IPC part, which is the infection prevention control part. So during this, what we did is we designed, first of all, we designed the flow of the patient flow and the staff flow, which doesn't mix together in order to prevent the spread of the infection or the breach in the infection. So we designed the flow of both the patients and the staff from in and to out. And then we also develop an SOP. Also, we decorating the donning and doffing sites where staff are, done during before they enter. So there was also a checkpoint where you check the patient, the staff before they enter to the center. At the same time, there is a proper mechanism where they will be, monitored while they are doffing to see their proper doffing procedure. So also this, not only this, but also we designed a way where we screen our staff while they enter into the center. So there is a mechanism where we monitor the temperature of every single patient, every single staff who entered into the compound, and we monitor their temperature at least as the initial sign for the infection. So we pick staff which are at risk or anyone with sign of fever. And this is some of the function we did during the IPC, but it's a lot. And the other part, we were working also the data management system, or we, as you know, that, as I said, this is like it's a whole. It doesn't have anything. It doesn't have a way you capture, the health data. So we were given the opportunity to create a mechanism where we need to capture a data. So we design our own registers. We design our own reporting forms in a way that we can capture our own data. Those data which already Dr. Ismail have already showed you are the source of that effort, because we create this platform where you can capture this health data from the wards and then to LIDAR and then to the reporting body. So not only designing the capture, we designed the storage, the analysis, and the dissemination, database where we store our data, where you can use it for different things like decision making for better. This makes this makes like the center. It's one of the few centers which really incorporates the quality unit into its functionality so that it monitors every time its progress. So based on figures, it's not just only by claims, but it is based on figures that have been displaying every single day. So we report this not only using our data for our own purpose, but also we disseminate those data to to the responsible bodies like the Ethiopian Public Health Institute, to the Ministry of Health, also to the Addis Ababa Regional Health Bureau, daily, weekly, and monthly, based on their requirement. So beside the data management and the quality, the IPC, we also have this quality improvement unit, which is under the quality improvement and clinical governance office under Millenium COVID-19 Treatment Center. So this unit the idea is it is a new, and it might be the only institution in the country which uses this opportunity, which integrating the quality, the science of improvement into the problem solving issue. So it is the scientific way you solve these problems rather than just solving as the every single problems. So there is this unit, the quality improvement, which design a lot of SOPs, which also solves problems based on the scientific approach, so that we were, if we have faced any problem in our process, we were capturing and we were tackling with this unit. So very important, very helpful during the stay in this treatment center, which still are the main functional unit part of the the treatment center. So overall, it is a biggest opportunity for me and for my colleagues also to work from scratch. Like, you don't have anything, but you build an institution which really works well, and seeing that it's a big honor, and being a part of with good team leaders like Dr. Ismail, which is a good listener and a good listener in case where you have your own problems. So it is a good opportunity for me to attend this platform and share my experience during this COVID-19 pandemic. And I would like to thank all of you for you listening me.
Very interesting. For sure, there is a lot of challenges, but I think that overall we need to appreciate the big effort of all of you as directors and coordinators, but also all your team, all your full health professionals. And I think now it's time to share some questions with the audience. So please, Jordi.
No, thank you very much. It's been a pleasure to have all you all today. We're having some questions. No, it was a pleasure to listen Iñaki first of all explaining the experience in Gambo and how Gambo was working together, with St. Paul's Hospital. How you could learn from them, and this is a very amazing view, from this part of the world, to see how in many countries the hospital in the capital helping the hospital in the rural region, and the opposite maybe sometimes, depending on the topic. Then we listen to Dr. Ismail. He explained very well how they transform literally how they transformed literally a center, a conference center, into a hospital, and all the congratulations, Dr. Ismail, because it was a very holistic approach with giving data, giving outcomes, but also asking yourself questions. No, I think it's very good, is because we are sometimes used to listen to people with data, but not putting this data into context with the holistic situation, and that was a very good talk, no? And Dr. Lydia explained very well what was the situation regarding all the needs and how they had to work on them every day. It was amazing how she explained that, no? And yeah, finally, Dr. Fira Olmame, it's amazing how you start, how the pandemic has triggered your capacity of collecting data, and how you have yourself, no, create this platform to collect data that give you this impulse, no, this impulsion to move forward, no, into collecting more data and giving this data to the clinicians and to making hypotheses, create studies, and this is great. This is great, no. So I have a question for each of you, no. Basically, Dr. Ismail, from all the potential list of innovations, no, that you have more or less have a list of innovations that you have created, no. I call them innovations because you have created them from nothing, no, from scratch. Which would be your top, on the top of the list, if you must rate the innovations? Which is for you the best innovation? No? I mean, in that sense that you would say, oh, this is the most innovative thing that we have done.
Thank you. And, I wish you could come and visit our center, because the most important is addition. I wouldn't call it design, because I think it has been done elsewhere many a great time. For us, the new addition is flow. Flow design was very important. Flow was very important for IPC. Flow was very important for protection of staff. And the flow was very important for making work easy for everybody. The other important thing is embedding improvement. When we started, we with a snap of a finger, we had everything in place. No, the embedding improvement, because if you have a problem, and if you have a scientific way of approaching your problem, you will solve it from day 1 to day 2 to day 3 to day 4. So these were first cause. Flow and embedding improvement system into the hospital. These were first cause. But if you tell me what excited you best, ventilation system, because we were afraid our staff might be infected. We could have diseases. We could have people being admitted to the ICU. We were scared, and we thought this is for the rich countries. Like 10 air cycles per hour, achieving 10 air cycles per hour, achieving a negative pressure this much and that much. We thought this was for Europe, for America, but we managed to do that in Africa at a very low cost. Now, not even in a planned, well-designed hospital, hospital which has existed in a building meant for a hospital, in a convention hall. We didn't have any ventilation system. No, I'm not speaking about natural ventilation or assisted ventilation. I am speaking about a mechanical ventilation which fulfills WHO CDC criteria for air cycle changes and negative pressure. Thank you.
Thank you very much, Dr. Ismail. Iñaki, has the pandemic delay your objectives regarding maternal health, regarding the neonatal care unit? I suppose yes, but with these delays, what have they changed your mind in some aspects?
Yeah, for sure. We never expect the pandemic effects Ethiopia and also Gambo Hospital. Fortunately, Gambo Hospital is not is not too much affected, but for sure we have its affect over all our projects. But we can, despite we don't have a lot of positive confirmed cases, especially in Gambo, we can say that the side effects, I mean, indirect effects of coronavirus affected a lot Gambo population. I'm talking maybe about the economical crisis we are suffering in Gambo Hospital. A lot of people, they are losing their jobs. It's to that due to coronavirus situation, the connections, international connections were closed, so it creates an increase of a lot of prices of the essential food, we can say. So especially in Gambo area, we're suffering a big famine hunger situation. So maybe we can say maybe this is the critical situation, and for sure this affect to us because mother are getting less food and also poor quality of the food, and for sure, you know, the malnutrition creates other disease. So the malnutrition also decrease our immunity system. So we can suffer other kind of disease. So maybe our main challenge due to the coronavirus is to fight against the hunger, against the famine. And for sure, malnutrition especially affects the under 5 children, who is suffering a lot, but also the pregnant women, that if they are malnourished, also they will have malnourished children, premature babies, small babies, and also malformations like spina bifida, myelomeningocele, that is critical situation and can cause the death of the baby. Because of that, our main challenge is to fight about this. Because of that, we need to strengthen, maybe at this time more than ever, this maternal and child health project. We need to improve, especially the follow-up of pregnant mother, to provide to all pregnant women the folic acid and these vitamins. Due to the poor food, the difficult nutrition, at least we need to provide with supplementary iron and folic acid to all these pregnant women, to do a properly follow-up, to detect the risk pregnancy, to refer on time to the referral hospital, and in our area is Gambo Hospital, and also to create the first neonatal intensive care unit in Gambo Hospital. At this time, we have a small neonatal unit that we want to upgrade and up to neonatal intensive care unit. And for sure, this project started with the support of St. Paul Hospital, and also now we hope with the support of St. Paul Hospital, that Dr. Firaol, that is here with us, he was one of the first GPs join Gambo Hospital, and with him we started the memorandum of understanding with St. Paul Hospital, that we hope this year, more than ever, this collaboration with St. Paul Hospital will benefit a lot Gambo Hospital, and also Dr. Lydia. She's a pediatrician, so we are sure she can help us a lot also in train our nursing Gambo staff, and also to improve our standard operation procedures, so improve our Gambo protocols, and make it possible this neonatal intensive care unit with the main objective of decrease neonatal mortality that in Gambo area, and not only also in Gambo, also in our catchment area, because we are not working on only in Gambo, we are working in all the catchment area, that it means more than 10 health centers, governmental health centers, that also we are supporting. So as a Gambo managing director, so we are working as much as possible, and we want to also to support with capacity building all the health centers in our catchment area. And as I told before, we are pushing international cooperation, but also we want to strengthen this national cooperation, because I think Ethiopia has a big capacity. Ethiopia has an excellent health professional, excellent doctors, and here we have the example of Dr. Ismail, Dr. Firaol, Dr. Lydia, Dr. Berhanet Sahai. All of them are Ethiopian. They are excellent, completely qualified health professional. I'm sure all of them, they can support maybe the most critical areas in Ethiopia, like Gambo Hospital. So in this way, I want to say that it's not, for sure, international cooperation is important, but we want to open mind and to say that national cooperation is also very important, because Ethiopia has a big capacity, has an excellent health professional that we want to use ourselves. So really, thank you very much.
And finally, Dr. Firol, which are your expectations with the data and with the pandemic accelerating your capacities? No, which are your objectives? No, regarding data collection in the next future.
Well,
The main part of the data management system is, to create the best culture for the use of the data for the future or for the current situation. So that's, first of all, that's what we implement. That's what we did. So we improved this culture of data use. So we designed everything: the capturing, the collection, the storage, the analysis, and the dissemination. All this, after all, goes for the increase the culture of the data users in our center, also in the ministry levels and the others. So based on our data, based on our informations, so nowadays we are showing that how important the situation is changing. Like previously, as you see that the most patients admitted were this just the mild cases, which later on changed into the severe ones, which we initially admitting. And also our data, based on our findings, we are reflecting that most of our patients who are really dying are most of these are some comorbid illness, like type 2 diabetic patients, which are significant up to, for example, for our last our previous study, it says about 37% of our patients who have died so far is having type 2 DM, which is really, it's the reflection of our these data. So this will be further a source for further study why diabetic patients are prone for infection. Also, it's not only this, but also we have a lot of information we are exploring and just displaying for the users. So in this regard, we are improving this culture, which have never been in the country, like because of this initiatives, which incorporates integrating the quality unit into the system, where you can use your data for decision making, policy makers, and for also researchers. So overall, what I have seen as my experience during this time is we create a situation where we can use our figures, data for our decision making, policy making, and also for a research tool.
Thank you very much. Thank you very much. And this is that has been an amazing chapter. We thank you all, and thank you very much for participating in Epidemics. See you soon in the next chapter of Epidemics TV with the launchment of Epidemic Studies. Thank you very much. Thank you.